There we go. Okay. Well, welcome, Vance, and your sweet baby. Teresa, do you want to introduce yourself?
Yeah, hi, I'm Teresa, and I work here in Colorado. I'm in an acute care hospital, um, and I've been doing it for probably like 25 years or so. Um, I just occasionally we get called into the ED to see patients, so that is definitely part of our realm. But we're seen mostly on the floor in acute care. But we do go down to see. A lot of it's just trying to figure out the disposition where the patient should go. But
Really good use of PT in the ED for sure.
yeah.
Teresa, what hospital are you at?
Castle Rock Adventist Hospital.
Awesome. Welcome. I live in Lone Tree, so I'm not far from you.
Okay.
All right. Did we get everybody? I think we did. Okay. We had 25 people register, but I guess maybe they found different things to do today, which is totally fine. Was everybody able to get the article? I tried to choose one that is available for free download, just in case people didn't have access. Awesome. So what are your initial thoughts about this article? I mean, I think if you just read the abstract, like, it's amazing, right? Physical therapy in the emergency department makes a huge difference. And when you look at the authors, none of them are physical therapists. So I kind of appreciate that they're doing research for us, which is awesome. But what are your thoughts on this? Oh, John went dark.
I've obviously spent a lot of time with this article, but I think one of the things that is most striking, obviously, the results are what we want to hear in terms of reducing, recidivism and return rate. But I think what continues to strike me is such the large gap that they had in their data set in terms of how many patients actually receive PT, that they actually had to scale down their control group, in order to be able to really match comparisons. And so I think it just still speaks to that large gap we have to face, in terms of, making people aware of the role that we can play with those patients, especially after falls.
Yeah, because I think the total number of patients that got physical therapy consults was like 3% out of all of those. And when you think about the number of patients, just the sheer number of patients that are coming in for falls, that's kind of staggering. I think the other issue is that we have, with that, they also said in the article that didn't even include probably all of the people that were being admitted for falls. So unfortunately, that just could be way more than that in addition to that. So one of the things that stood out to me on that first page in the introduction section were the geriatric emergency department guidelines. I'm pretty sure that Teresa's using those for sure. Or I'm sorry, Susie. Is anybody else use those in their emergency departments? I was not familiar with these, so I thought it was really helpful to look through that a little bit. And I'll link that here for you.
I will say too, and I have a little insider track knowledge that they're actually, because those came out about 10 years ago, we're right in the process right now of reviewing those geriatric emergency department guidelines and doing an update on the evidence. Those were largely based on kind of practices that people were doing. And so now we're taking a little bit more of a standardized approach. So I actually have the opportunity to work on the group that's looking at falls, and we're actually trying to do a systematic review of PT role to try to actually embed that into the next guidelines to make a more clear stance on the role that PT should have in those guidelines.
Yeah, and I've been talking to some geriatric specialists, and I'm going to be interviewing a physical therapist who practices in home care about what she wants EDPTs to know about referring patients to home care and the patients that they send into the emergency department. And she feels like these guidelines are outdated as well. But I just was shocked that I had never even really been exposed to them. The other thing I found that includes the same author, Adrienne Lesser, was a systematic review on geriatric emergency care to help prevent falls. And I'll link that here for you too, so you can take a look at that. That's from 2021, so it's a little bit closer to updated. I don't know if you're familiar with that as well, Susie.
Yes.
Susie's the boss on this.
The other thing that I'll link when I'm not driving anymore is there's a group called the Geriatric Emergency Department Collaborative that actually puts out kind of more just-in-time resources and tools for practice patterns, based off those guidelines that are used for accreditation. And I know they've got some good stuff about falls and mobility practice, and then all the other different principles of geriatric, delirium, elder abuse, etc. So I'll try to put that into the link here when I'm less mobile.
That's great. And I'm going to link all of these different things on my website, just so people have access to all of these resources when they're trying to look for appropriate resources for their geriatric population and how to improve their practice in the emergency department. One of the other interesting things to me about the data and the methods were that they didn't include any managed Medicare. So I personally see a ton of patients with managed Medicare who are presenting for falls. I don't know if that's the same for everybody else, but that population is also being left out of this data set. Does anybody else have a lot of experience with managed Medicare, folks?
Yeah, I'd say about probably half of our population is managed versus traditional.
Yeah, I mean, I think in some ways it helps us get our patients placement a little bit quicker. In other ways, it takes even longer. But I did notice that they weren't included here. Okay. Anybody else have anything that really stood out for them?
The only other thing I was going to say that I thought was interesting, just from having looked at some of this data in our own system, is they didn't quantify if they had access to it, anything about prior function or particularly living situation. And I think we know in our system, about 20 to 30% of our patients coming in for falls are coming from skilled nursing or from higher levels of care, and so knowing if those are patients that are necessarily going to be triggered for referrals to therapy in the ED, I think understanding that was one thing that, kind of stood out to me that wasn't available in this article.
Yeah, I think a lot of the other thing that I would have liked to see are like, what were the primary reasons that these patients were coming in? They included that if they had any kind of fall diagnosis, they were included in this data set, but not really like primarily why they were there. So I think that would be interesting to know as well. Because if they weren't there for primarily related to a fall, what were they there for? And so I think that might indicate why some patients weren't referred to physical therapy in that particular case. I did like that they didn't include anybody who went on to be admitted to the hospital. I think that was a valuable use of an inclusion criteria, just to make sure that we weren't looking at people who were sick enough to actually be admitted to the hospital, but did include the patients that went into observation status, because a lot of our folks do. Does everybody's emergency department here have an observation unit?
Mm-mm.
John, your whole hospital is an observation unit, huh?
The one hospital in Duluth had an observation unit. They called it the CDU, Clinical Decision Unit. And then sometimes the ED bed would just be flipped to an observation bed if they were there long enough. But that hospital had like 50 beds in the ER, so there was space to do that sometimes. The one that I'm in right now is yeah, it's a little bit different. Everything's a little tighter. So, but Nantucket so far has been a very different kind of population, where it's like tough old people that somehow get home.
We call those ranchers in Colorado.
Yeah, that's kind of Nantucket. Like, you got billionaires and tough old people. That's your combination.
The Wash-ashores or the come-ashores, is it something like that in Nantucket?
Right. Yeah, exactly.
That's awesome. Well, our facility has 2 CDUs. We have a CDU that's primarily for medical observation, and then one that's more related to mental health or substance abuse observation. So we kind of dabble a little bit in both of those, but we do see a lot of patients in observation for a number of reasons. The other patients that we're seeing in the emergency department a lot more recently are patients that are being boarded there because the hospital is too full to keep all the patients. And so I think those patients are going to be excluded from this particular article, but I know that we are seeing more and more of these patients. And I suspect as access to healthcare continues to be an issue, that's going to be more happening in more and more emergency departments. We're thinking about bringing on a third PT in the emergency department just to help manage those patients who are already admitted, but have nowhere to go. And the other question I had for you guys is like, what is your bounce back rate measured at your hospital? So this article looked at 30 days and 60 days. I know our emergency department really measures 9 days as the like bounce back time for same diagnosis or same complaint. And I didn't know if other people have this as an outcome measure that's important to their facility, that they're being held to as a standard, or if you've collected any data about your individual programs' bounce back rates.
Mm-mm.
Ours was 30 days in Duluth. I'm not sure what it is here in Nantucket.
We look at 72 hours and 30 days.
We definitely do 30 days. And then I want to say it's like maybe, I know we definitely look at a 24-hour, like if you were here the day before with the same problem and then you're back.
Yeah, and I think that's interesting. I had a patient on Friday who it was like her 6th emergency department presentation since she had been discharged from the hospital for a surgical procedure. And she just kept going home, but clearly was not being successful. So I think in addition to looking at bounce back, we should look at like the whole episode if there's a precipitating event. I think a lot of times too, our patients are going to other emergency departments and we might not know. So sometimes we do know, sometimes we don't know, but I think that's where we're losing some follow-up information as well. Were the patients dissatisfied with their care? Did they go to another hospital? Or did they call an ambulance and end up in another health system? So it's hard to know, but I think it's another important thing to kind of take a look at when you're looking at patients. How many times have they been to the emergency department in the last year? How many times have they been here for a fall? I also look and see, are you seeing a physical therapist in our health system? Sometimes that's helpful information, and then I can contact that physical therapist to ensure appropriate follow-up. So I find those things to be pretty helpful. I had a physical therapist who sent a patient into the emergency department for imaging because they were concerned about their red flag symptoms with their back pain. And it was a really great catch. The patient ended up having a metastatic cancer that had been undiagnosed. So I do think that information is helpful when we can access those patient records. In this article, there was a reference to the new injury severity score. I had never heard of that before. Is it just me?
That was new to me as well.
Yeah, I had not heard of that before, and I haven't really been able to find it. And I don't know who scores that or who makes that decision. But I thought it was really interesting in the context of the article that most of the patients that were seen by physical therapists were rated a 0 on the new injury severity score. And I think partly that's a good thing, because then maybe we're seeing these patients before they're injured and we can change the trajectory of their care. And that's a really upstream place where we want to be. But I'm wondering why we're not getting involved with those patients with mild, moderate, or even in sometimes severe injuries. Any thoughts on that? Hi, Stephen. I feel like that guy in Ferris Bueller who's like Bueller. Maybe I'm the only one old enough to remember that movie. Classic. So I thought it gave us a lot of space to intervene with patients. And if it is something that's used in your facility, I think it would be helpful to be able to say, hey, like we might be able to intervene more with patients who are scoring on this scale, but it's not something I've heard of before. I also thought it was interesting that they said that NISS score of 0 does not necessarily indicate the absence of injury, but may indicate that an injury or injuries are not considered sufficiently acute or traumatic. So those patients could still be having issues, just they decided that they weren't severe enough. I also think a lot of our patients who are coming in with falls may not have injuries, but may have underlying illnesses that are contributing.
I also wondered too, and we've seen this, we use the ESI, just the Emergency Severity Index. I don't know if other people use that. And, most of the time, when we looked at our data for the patients going home after falls that were being seen in the ED, they were scoring in that like 2.6, kind of in that moderate range. I wonder if some of those more severe injuries are people who are getting admitted, which is maybe why
Yes.
we're not seeing those necessarily. But I do think sometimes there's a tendency not, there's still, and I've been in conversations with other folks, there's still that desire not to over mobilize people who've been injured. And so I think there is that opportunity for us to get involved with more of those folks who could be managed at home and could be seen and discharged, with additional injuries.
Yeah, and this NISS score that they rated in the article here, it was like the bulk of the patients were no injury, which is great. And then they rated it minor, moderate, serious, severe, and critical. So 0 patients were seen by physical therapy that were critical. I think that's fair, right? Like we need to get out of the way and be the right provider at the right time. So we're not obviously going to be that person. 18 were severe, 52 serious, 519 were moderate. So we're still getting a pretty good involvement there, I guess. Probably not based on the overall data set. Only 367 in the minor injury category, but 17,000 PT consults were completed on patients in the 0 injury realm. So I think there's definitely room to improve that there a little bit. Of the primary diagnoses that were seen by the PTs in this article, 11,000 were injury. So I don't know what necessarily that came out to be, but then the next highest were musculoskeletal issues. So I think that kind of shows our benefit there, and then kind of divided out by other medical conditions there. Other statistics that I thought were interesting were that the bulk of the patients that were seen were over the age of 85, although the average age was 82. Many more women than men. And then our race demographics very much skewed toward the Caucasian end of the spectrum. How do you guys feel like that compares to the patients that you're seeing?
I feel like we see, like, I don't know, we're struggling with the falls where like we're trying to get involved in people that they fall, but they're mobile enough to go home. So we could try to get them home or outpatient. But like the providers are like, oh, they can walk, so they're fine. That's like where we're struggling. So I don't think we get a lot of orders on the people that have more mild injuries. We get ordered on the people that come in and they like no one can move them. So they're like, what do we do? So that's where we're kind of definitely struggling. But it is typically I would say it's definitely more probably people in their like 70s or 80s for the falls.
Yeah. Do you find that you have need with those patients that are more involved to consult occupational therapy in your emergency department, or is it just physical therapy?
They do not consult occupational therapy in our emergency department, which I mean, I think that we could eventually get there. They used to consult both of us at the same time to get people into rehab, and then they realized they could get people to rehab from the emergency department with just a PT note. So
well, you're fancy.
Yeah, I don't know how that works, but it is. So that's kind of that. I think that's unfortunately how OT got kind of phased out of there, because they were like, well, if you can just, they kind of had us do kind of a bit of a screener with like the AMPAC and stuff like that for the OTs. So we can kind of like try to infer how poorly they would do with self-cares, and then we can get them to rehab just with a PT note.
I just consult OT myself. I'm like, yes, I just want you to know that I put in OT orders with your name on them and they're coming down to see the patient now. So that's kind of how I manage that when it's needed. I think that we're doing a disservice to our patients when we're not consulting OT. There are some good references about occupational therapy in the emergency department, particularly in our patients who are experiencing homelessness and having difficulty from that perspective. Also, how many patients are you seeing that come in for altered mental status or for medication errors? Or like I had a patient who came in that hadn't eaten in 8 days because she just couldn't figure out how to make herself something to eat. And she was concerned that she wasn't having enough output into her ostomy bag. I'm like, well, if you don't eat food, it's really hard to have enough output. So to me, that patient really needs occupational therapy much more than she needs me. I mean, she's mobile, she's able to do all of these things, but she's not. So there's a disconnect there from either a health literacy standpoint or a cognitive issue, or just needs some help completing ADLs or problem solving support around that. So I would personally like to see OT get a little bit more involved in the emergency department and these patients who are falling and not succeeding at home.
Addie, are you guys embedded, or is it just consult from the floor?
We started consult from the floor, went to being embedded. COVID got really, really bad, and then we went to being consult from the floor again. And now we're like a couple weeks in. Now we're back to being embedded.
Okay.
So
Welcome back.
thanks. Pretty excited. Now, the nice thing is now we kind of were pushing on those people that came in with like cognitive errors, medication issues and all that. And now we actually can we're allowed to put in a referral for like a senior health consult. So they go see a geriatrician in the next like week or so who does all of that follow up with them. Cause that was our big concern, is like, we're like, you're consulting us on people that like their issues are not really 100% PT. It's a lot more other stuff that someone else needs to address.
We had a falls clinic for a while that we would refer people from the emergency department, and they would be seen by a geriatrician, a pharmacist, a physical therapist, and an occupational therapist all at once. Like they would do kind of back to back to back to like help prevent falls, and they would do regular checkups with them. If they felt like they needed to be referred to other therapies, they did that. And then the physician left and it just totally fell apart. So I wonder how we make these models a little bit more sustainable. And it sounds like Susie probably has the data to help us figure that out.
Yeah, we haven't quite cracked that issue in terms of the long-term clinic solution, or where we necessarily send those folks to. Right now, we've really focused on that primary care follow-up within 7 days of discharge, and then really linking. We're really lucky in our system to have a pretty robust outpatient therapy department, throughout our health system, as well as an integrated home health system. So we've got really easy networks to connect. So right now we've been doing a little bit more a la carte than a true clinic for those folks. And then we were also really lucky to have some pretty robust case management in our ED. And so linking those case managers to really kind of pull all those other pieces together and create a package around those patients at discharge, I think has been part of our success.
That's fantastic. Today on Twitter, I got into a little discussion with some people about falls. And should there be an automatic order set for falls for any patient that comes into the emergency department with a fall? So I'm interested in your thoughts on that. And then what information from this article would you use to help you support that if you were going to go for that in your emergency department? Because I think there's some real gems in this article about best ways to help us not just maybe have a global consult, but to help us narrow down who would benefit the most.
The automatic order set, I could see having some problems, because you'd end up having a lot of patients who are not appropriate for PT. I mean, it seems like it'd be nice. We would catch everything, but I kind of think back to like the acute care. It had gotten to a point where literally everyone admitted to the hospital was just blanket posted for PTOT all the time. And there'd be like 200 some consults like every day. So like, and I'd say about only 40% of them actually needed PT and OT. The rest of them probably would have done just fine walking with a CNA or an RN. And so like, getting blanket posted in the ED, I mean, it's helpful for the practitioner that just wants a black and white algorithm. Patient A walks in with A, B, and C, and you click button D, F, and R, and then you've done all the right things and reduces all clinical reasoning. So I think like in one way it'd be really nice to have that because we wouldn't miss stuff. But on the other side, I think it's probably better for the clinicians and the therapists and the nurses to work as a team to identify the right patients for the PTs.
I think you're absolutely right, because you don't want to spend a lot of time trying to triage patients. Our emergency department has over 100 beds in it. Like if they put in a consult on every patient with a fall or every patient with pain, like it would be spending a lot of time just trying to figure out who needs to be seen the most. So I think that's helpful. And I think this article gives us a few ways to help narrow down the folks who would benefit from the most. Does anybody have any thoughts about that?
Yeah, I mean, I agree with both of you, and I always worry about, over flooding the consults to the point, where people get missed, and then now you're not seeing everybody, and then that, that argument for the utility, I think sometimes goes away. At the same time, I think, we've seen in practice that, if you wait until multiple clinicians have had to kind of look and decide, is it right to put that order in? Now you're waiting an hour, into that ED visit, and now you're getting so close to the time of dispo that anything that PT is saying in terms of, recommendations, things that need to be done. Now there starts to be this tension with delaying discharge and extending that ED length of stay. So I still think there's benefit to as much screening and clinical decision making that can happen early to really initiate that order or counsel as early in the visit. One thing that we've used, and again, this is something that's built into geriatric emergency departments, is some type of screening for vulnerability. And so we use what's called the ISAR, the Identifying Seniors at Risk. It's a screening question that's done by nurses in triage. And so it asks questions about, are you needing more help with mobility or ADLs in the last few days? Do you live alone? And so it kind of helps to identify those folks who are going to be at a higher risk of vulnerability. So we've used that as part of our kind of pathways that we've identified for falls to help in that decision making, along.
Susie, we lost you.
I'm still here.
Oh, there you are.
Yep. So that's something that we've used in our processes.
That's really helpful. I just linked an article there about that. One of the things that I liked about this article were kind of the different comorbidities that they identified as being more helpful, just to help narrow it down a little bit. I'm trying to find my list of people, but I thought it was interesting that the odds were greatest with a revisit with patients related to having Alzheimer's disease. I don't think that's necessarily too surprising. But I think that's a huge opportunity for us to get a little bit more upstream with those patients in other settings. Like, how are we managing those patients from a physical therapy perspective to help keep them as safe as possible in their homes or in their facilities where they might need to be taken care of? Trying to find my list that I wrote down.
Kind of going back a little bit, and I don't know how other people have started their programs, but the way that I've been doing it is the ER has like a track board that you can see everybody that comes in, and it'll say right on there, knee pain, fall, vertigo, something like that. And I usually will just, they're 87, so I start looking at it. And if I start seeing, that they're ordering x-rays or this other thing, I'll go find the doctor and just say, hey, I notice you have this person here. Do you think they're going to need me to look them over? So it might in part be the therapists who are building the programs, to intervene right away when people come in, just having an eye, a pulse on what's going on and asking for those consults. And usually just starting that conversation early is how I've done it. And then I trained the other therapists to do the same thing. And then after a few years, then you just start, you start, the doctors and the nurses kind of get trained. They're like, oh, so and so came in. They start to get an idea of who needs to be called. So I'm thinking of you, Addie, how you guys haven't been in there for a couple of years. And it seems like you're getting the consults when it's almost too late. Like oh, we don't know what we're going to do with this now scenarios. And you're not getting all the other ones that you could be getting, I think, by just asking for the consult, like when you see it. And that's, Rebecca, that's why I say I'm like a hybrid embedded model. I'm not necessarily working in the ER all day, but I'm watching the track board all day on Epic.
Totally proactive. Yeah, I think that's the way to go.
So as
If
soon
you
as
have
I
time.
see something, right.
If you have time. Some days I'm like on that track board, like on it. Other days it's 5:30 and I haven't had lunch yet, let alone open the track board, because it's so crazy. Like this weekend we had, I don't know, it's apparently military drill weekend in Colorado. A whole truckload of guys came in. I don't know what they did, but it didn't go well. So, like there are days when that works great. And I think that's a great suggestion for Addie on how to like increase the business that you're getting and help make things a little bit more standardized. I think rounding with your providers is a really good way to do that as well. At shift change, I like to go through and be like, hey, this patient's been here for a while. Like, I think now would be a really good time for us to see this patient. Also reminding them when you're there till is a good way to start that conversation. Because I find that sometimes providers will say, well, I think we might need to do a CT scan and I want to make sure all of this is okay before you see the patient. And then you say, hey, I'm going to leave in an hour. So I think, if you think that this patient is probably going to need physical therapy, let's consider whether it's safe to do that now. So that kind of prompts them to think through to the end a little bit more and gets them to think about what they anticipate will happen with that patient so that we can get involved a little bit quicker. But John, I like how you're being proactive, even though you're not necessarily in the space, you're still managing your zone.
Yeah, I got all the, it's kind of, we have we can text using a Volt system. And so I can not necessarily be in the ED and shoot a text to the doctor, just be like, hey, what do you think? And they'll say, oh, I'm going to do this image. But yeah, maybe. And so I'll just have it on my radar. So that's how we're able to do it without me necessarily being present all the time. I think in Duluth, it was super helpful starting it being present because, the way I always said it, if you're not literally behind the doctor when they turn around, they have already moved on from that patient. And so it's like they have to see you to remember that, like, oh, therapy, yeah, because their memories are like 1 to 2 minutes long.
Very much like squirrel.
Yeah, pretty much.
To be fair, I feel like EDPTs are a little bit like that too. I'm not going to speak for you, John. I'll just speak for myself. That like multitasking, like, okay, let's move on to the next thing. So some of the comorbidities that are listed in here as most commonly associated with fall risk, I think are interesting. The first one they listed was depression, anemia, diabetes, Alzheimer's and related disorders, osteoporosis, osteoarthritis, heart conditions, history of heart attack, atrial fibrillation, heart failure, ischemic heart disease, stroke, or TIA. That is so many of our patients that come in. So I think you could potentially build an algorithm around that. You could use some of this data in here to kind of identify the patients that are most likely to fall based on this Medicare data. We've got higher female population, higher average age. Those things could help you identify more of a pathway if you have an emergency department that's very algorithm focused. Like if those patients meet 1, 2 or more of those criteria, they automatically get an order set versus just consulting on everybody. I have a number of providers who say, oh, they don't need a CPT, they just had a mechanical fall. And I'm like, right, they had a mechanical fall. So, and I'm a mechanical person, so maybe we could just take a look at that versus a patient who had like a true syncopal event. And I'm like, yeah, like you might want to look at that for another little minute before we get involved, but I also want to see that patient. So I think those are some gems from this article that we could pull out to help us focus on who are the best people that we see. I think the other thing that would be helpful with this article is what happened to these people at discharge. What was their discharge disposition? How many of them went home? How many of them had home care services initiated? How many of them went to subacute rehab, acute rehab? How many of them got outpatient PT follow-up? Because I think that's a huge piece of missing data about whether or not they came back in those 30 to 60 days. If they went home with no resources, they probably were doing pretty well and may not have needed as much physical therapist intervention, but the patients that I'm thinking of who really need to see a PT and the ED often leave with a lot of support around them. So I think for me, that was the really big thing that was missing in this article. I do a lot of placement. I do a lot of home care referrals. I know what I send to home health therapists. So I really am looking forward to talking to some home health PTs about their experiences with patients coming from the emergency department. But I'm wondering what you guys think about that. Like, how many of your patients are you sending home with no support or no other resources, with no new DME? Like, really, truly, they didn't need anything from you, but your one evaluation or intervention was the thing that made the difference.
I would suspect that's pretty unlikely. I mean, we do a pretty robust referral to home health, more so for our general geriatric population than the falls, referrals to outpatient. But one of the things we've looked at is attendance rates with that. And so, I mean, it's one thing to place those orders to have people go to those, but the other thing is, do they actually do that follow-up? And I know, we've done our little study we just did looked at that in patients who had the orders who didn't attend, their return rates were quite high because again, they weren't, doing that follow-up care. So, I think we all know that our one visit in the ED isn't going to be the magical thing that's going to change that patient's trajectory. It's really that connection to all those resources and services after the fact and getting them in the right place at the right time.
And that's a huge part of what physical therapists value is in the acute care setting as well, right? Making those discharge recommendations to keep patients home and safe, or in rehab and safe, where they need to be next.
I want to go back real quick. You were
Yeah.
talking about the mechanical versus, the physiological falls.
Yeah.
One of the big debates I get into whenever I'm trying to bring a new kind of falls pathway into our EDs and integration is the idea of orthostatics and looking at people who are orthostatic. And I'm curious what people's thoughts are on that.
Or dizzy.
Right. And my personal opinion, I've had some nurses say, well, if they're orthostatic and they've got positive orthostatics, we're not moving them. And I'm thinking, but you're going to discharge them home. So somebody should.
Or they put people on oxygen, right? And I'm like, well, but do they use that at home? Well, I don't know, but they were satting low. So I put oxygen on them. And I'm like, okay, but you just took it off of them and now they're going to go home.
Right.
So I take oxygen off of everybody who doesn't use it at baseline just to see what happens. And I take vitals on all of my patients to see what is physiologically happening with them with mobility. Because I think you're absolutely right that it's a huge issue.
And I think, there's benefit in them doing those, as part of a need for additional cardio workup. And if there's other things from a medical standpoint, and, I encourage if the person's coming in with that syncopal episode that they do those first, but then it should be figure out what's going on and then have a PT figure out how to teach them how to manage that when they're going home in terms of how they're going to mobilize in the home and if they're going to be getting up and all those kinds of things.
Yeah, and I think us making those recommendations to nursing as well, like how can we help the nursing staff feel comfortable mobilizing those patients? Like, does this orthostasis improve if we do a cardiac warm-up before the patient stands up and mobilizes? Do they need to have a wheelchair follow with them? Like, do we need to speak to the medical team about hydrating this patient, or is there medication titration that's necessary? And I think we do have a role in making those recommendations as much as we can with these patients. Stephen, I'm seeing your comment here. Do you want to tell us a little bit more about that? Because that sounds really inefficient. So Stephen has in the chat that working in the VA system, they have to be admitted. Oh, fair. Everybody's got their kids right now. They have to be admitted to make DC recs other than home. And I felt like that was kind of where we started, like that the patients had to be admitted. But then in the setting of the pandemic, like there just was not any capability to do that. Like we could not be admitting patients. And really, isn't our goal for these patients, particularly our older adults, to reduce hospitalizations? So it makes no sense to me to be admitting patients that can successfully medically move on to the next step without admitting them. There's a cost savings, there's a decreased risk of falls in the hospital, there's, you know, a decreased risk of new infections, of new wounds. Like it doesn't make a lot of sense to me. I do have patients who, when they have to be admitted, because it's going to take 72 hours to get them placed, or there has to be like a medication adjustment or something like that totally makes sense to me. But I think that we need to try and move these patients a little bit quicker. When I have VA patients at my hospital, it can be very frustrating, just that you know that they'll probably get all the care that they need eventually. Like you say, everything moves a little slowly. It's so hard to get equipment for those patients as well. They could just go home with a piece of equipment, but the VA won't approve it. That's hard. Teresa, how is it for you? Do patients have to be admitted to your facility, or can you discharge from the ED to a facility?
Most of them are admitted, but we do have our resources, I think, are kind of limited at times. And so they're usually admitted. We have a few that they're able to set up to go to like a nursing home or something, but I'd say majority is admitted.
We just truly don't have the bed space to do that.
Yeah, I mean, that's been a problem, especially with COVID. A lot of them spent days in the ED.
So many days.
Yeah.
And that's not good for these patients either, right? Like you have patients who are
No.
sundowning, you have patients who are confused, you have patients who have a huge delirium. I don't know about your emergency departments, but windows are not really a thing in the emergency department for the most part. And so I worry about those patients that are holding there for days at a time. So the nursing ratios are sometimes not great. The access to like a bathroom is limited. It's so difficult to have patients mobilizing safely, making sure that their fall risk in the emergency department itself is reduced. Any final thoughts on the article? I want to be respectful of everybody's time so that they can move on to whatever else you need to do tonight, getting your kids tucked in.
I think it was
three
very
going to
neat
bed
to
too. Sorry, go ahead, John.
hear. I think this was really neat to see this article discussed, you know, and picked apart in ways that I definitely did not do that when I looked at it. So thank you.
I love
Yeah.
the bottom line though. The bottom line is super helpful. If you haven't started a PT in the ED program, or you know somebody who is, this is a really good article to get the attention of your hospital's falls committee.
And I would echo that there's a lot of movement around geriatric emergency department accreditation across the country. That's a movement that's really spreading because there are so many vulnerable patients. They're looking at better practices, you know, across that continuum. So I mean, we found that was kind of a magical way to get stakeholders really excited about PT's role when you started to look at that lens. So if there is that kind of an initiative going on in the hospital, it's another kind of nice pathway to ride along with.
Any other final thoughts? Well, thank you guys for coming. I've never done this before, so it was super fun to do this, and I hope I'll get better at it, but I appreciate you bearing with me and joining for this. I really want to make a space where we can connect and share ideas and talk about things like this and how we can make what we do better. I would also love to feature any of you who work in the emergency department. I'm trying to highlight as many emergency department PTs or people who work in the space in any capacity as much as I can. So if you're interested, please reach out to me. Also, I do have a webinar on sale right now for digital triage to keep patients out of the emergency department. I was thinking about you, John, with that. Like that might be a way for you guys to actually keep patients out of your hospital by implementing digital triage in your outpatient clinics as a way to kind of keep patients from coming in the first place and getting them into physical therapy where they should be. And then we're going to have some content soon about geriatric considerations in the emergency department. Susie, I think you'll probably know all of that, but for those of us who aren't experts, I think it'll be helpful. Also, one on mild traumatic brain injury coming as well soon. So keep your eye out for more of those things. I hope to do the Journal Club quarterly. And you can find the people that I've highlighted previously on the website. And then I'm going to put my email in here so that you can email me if you're interested in being highlighted, you or your program. I would love to feature you. Thank you, guys.
Thank you.
Have a great night, everybody.
Thank you.